You're listening to On the Way Home with your host, Emmy Kelly.
Welcome back to On the Way Home. Today's conversation sits right at the intersection of health, housing, and systems change. I am your host, Emmy Kelly, and today we are joined by Dr. Andrew Boozary, a physician and health policy leader whose work challenges the idea that health begins and ends in the clinic. In this episode, we explore the creation and impact of DunHouse, a groundbreaking model that brings housing and healthcare together under one roof, and what it teaches us about shifting care upstream, measuring successes differently, and designing systems that actually respond to people's real lives. Let's jump in. Thank you, Dr. Andrew Boozary, for joining us on the show today. So excited to have you, and thank you for making the time for us.
I really appreciate the invitation. Thanks for having me.
So we'll start with our signature question, and I know you've come on the show before, so you've answered what home means to you. If you have more to add to it or how it's changed for you over time, if it has, please do share.
One of the things that I've been really privileged to see, and we'll talk about it today, with respect to DunHouse, which is the housing initiative by the hospital at UHN with partners, Fred Victor, United Way, in the city of Toronto, and every level of government. Seeing it now out in the world and being able to be there every day, every week. To me, the home piece, which to really capture, is around community. I think that's the element that we're starting to see really take shape at DunHouse, is how people care for another, being able to have that stability, be able to choose what health and well-being looks like for themselves, being able to have that kind of permanence, that kind of rooting. And as that's happened over the first few months, now into the year, how those roots and trees start to entangle to build something even stronger. And it's amazing seeing, some of the younger patients at DunHouse look out for some of the older patients and vice versa. Always have people sort of stopping and say, so-and-so didn't look right, or I don't think they're feeling that well. And, sort of have a checkup or catch up with them. And honestly, it's been one of the most moving things now a year out from DunHouse coming together. So continue to learn about what home means, what housing means, and what that means with respect to health.
The community size, I'm just interested in, for our listeners, how many people are in that community that's shaping there at DunHouse?
Well, there's 51 people that live there. And there's an amazing Fred Victor caseworker team and support team that's there 24/7. And then we have really phenomenal partnerships with the neighborhood group, with Indigenous Health Program at UHN, with UHN nurse practitioners and inner city health associates for psychiatry and various mental health and addiction supports. So it's really this amazing circle of care, this integrated care between health and social care. And most importantly, I think it's just the human interaction of looking out for each other.
Can you, to begin the show, can you tell us a bit about what inspired the creation of DunHouse, and how does it reflect the core principles of social medicine and practice?
So the idea of social medicine is not new. And really this goes back in Western medicine to Dr. René Vermeer in Paris, who was one of the first physicians to publish the findings that people living in lower income neighborhoods or arrondissements live far less than people living in high income neighborhoods. And that effect was so powerful that Vermeer actually left clinical practice to become an economist. And this is what I've written about as the pathologies of poverty. And so where we're now in 2026, pathologies of poverty take shape in the issues of affordability, of homelessness, of challenges to access food security. But really the most powerful driver, determinant of health, is whether someone has access to stable and safe housing. And this has meant, across jurisdictions that people live half as long as the general public. That's a staggering statistic almost 200 years later from when Vermeer published early findings that is unconscionable. Again, if there was a drug or treatment to reverse 10 to 20 to 30 years or restore decades of life, you would think every funder would be tripping over themselves to bring this to market. And the reality is we know what that treatment is. It's housing. So that's really how it ties to the concept and core of social medicine. That's so much of one's health outcomes, one's own perception of health and well-being is really socially derived, and a lot of it by social policies and social policy decisions that are made upstream or away from the clinic or hospital that I work at. And so DunHouse was really born out of that idea. When we looked at the data, something that pulled with the team, around 50 to 55 patients making up over 3,000 emergency department visits. Or if you zoom out a little bit for downtown Toronto, it's about 234 patients that made up over 15,000 emergency department visits in 1 year. The realities are that people were coming to the emergency department with nowhere else to go, or their health conditions were deteriorating and needing to come back for more acute and more serious medical help. And so that premise, that principle that we saw of only being able to provide Band-Aid solutions at a hospital level, and this real push and drive that the UHN leadership and UHN board deserve credit for, to say, are we going to be the University Health Network or the University Healthcare Network? And if we're really serious about health, we need to be thinking about our contributions. And that was really where the decision to donate and dedicate a hospital parking lot with the City of Toronto, with United Way and the federal government, provincial government, to build DunHouse, which was 51 housing units over 4 stories, with many of the various supports we just talked about, to come into place to provide a better solution, a more humane solution, and a more cost-effective solution than what we were paying for currently as the public. And I think the argument is, if we don't invest in housing, we're paying even more to the prison system, mental health system, the shelter system, to try to, again, provide suboptimal responses to what is really a chronic policy failure that is playing out in individual lives every day.
So just to be clear, am I correct to repeat that you said that homelessness does shorten a lifespan by half?
By half. So
on average.
On average, and you can see it, various reports see it between 20 to 30 to 40 years, a more recent estimate. And some work in the Toronto level saw that, especially for chronically unhoused women, there was a 40-year life expectancy gap. I mean, that is damning when you look at the consistent disparities for Indigenous populations in various parts of the country that have seen a very systematic lack of access to affordable housing, to safe housing. That has been a major driver in where we've seen the health equity challenges, refugee newcomer populations, and again, really where the structural vulnerabilities now are playing out for older adults. There's more and more data that people over 65, over 60 years old who are chronically unhoused are now showing up to shelters or living or sleeping rough at a rate we just have not seen before.
It's sad, like you said, damning for sure. We have heard a lot about the impressive impact of DunHouse since it opened. What outcomes matter most to you, and what have you learned about measuring success when you look beyond traditional clinical metrics, especially as DunHouse works to shift care upstream? And maybe indulge us a little bit in some of the data that I know you already have kind of been tracking and collecting to show, in numbers what that success has looked like.
I'm going to start in the opposite order and start with the healthcare utilization data to your question. And then I'm going to get a bit philosophical about some of the personal interactions that I've had that are continuing to shape my thinking about what matters and what we're measuring and what can we measure. When we go to the granular level around some of the really important data that's in place, we've seen a 79% reduction in emergency department visits for people being able to now stay and receive the supports at DunHouse. So that is incredibly significant when you think about the costs of an emergency department visit, the strain on emergency department visits, and the really terrific healthcare teams that are trying to navigate much of what is happening across the province and across the country in terms of trying to respond to the acute medical needs. We've seen a 52% reduction in hospital bed days or stays in hospital. That, from a health economic perspective, is even more significant because an average hospital bed stay in Canada is over $2,000 a night. So that, again, continues to see just on the health economic shift or savings or cost avoidance of DunHouse in the first year, that's over $2 million for just, again, a very select number of individuals, about 51 individuals. When we look, again, at the economic breakdown, that really means that it's over $50,000 a month for someone to stay in the hospital and less than $4,000 a month for supportive housing. And that, again, for those that don't really resonate or buy into the human dignity element, where I fundamentally believe housing is a human right and that healthcare is a human right, I think the economics are very compelling, regardless, again, of where your position is on housing and its applicability to be scaled. My sense as a clinician in terms of what really matters the most to me really is the dignity. The fact that if patients are palliative, that they can pass away in their own home, as they choose to be with family, without family, they are able to have that autonomy and that self-determination about their own life. I don't know how you price that. You know, I've seen that now at DunHouse in terms of where people are telling me that they're able to reclaim joy, reclaim doing the things that bring them meaning, and whether that's making art, whether that's in being able to interact and socialize with people in a safe setting. These are the things that I think, you know, we sometimes see lost in this very polarized debate around homelessness, around public safety. And I think when we see the data around the health outcomes and the safety piece, it's really this cruelty towards people who are unhoused, chronically unhoused. And this is where we've seen, I think, some dramatic effects in the first year of DunHouse's existence in the world.
I have to ask, do you think, like, what you've shared so far is just so incredibly compelling? And like you said, there's probably not really an audience that can disagree. You've got to care about something that you just said, whether it's human impact or dignity or just plain old economics. Do you think that you're being heard? Do you think that this is getting traction, like the type of traction that it needs for Canada?
We need more. You know, I think there's been, again, some traction, I think, around some of the results. I think some of the human stories. Again, I have to say, if people haven't had a chance to read this story in the Toronto Star about Jason Miles, one of the tenants who's been a fierce advocate, by Victoria Gibson in the fall of last year, please do. I don't think there's a more powerful story and account of what access to housing has meant. And I think we just really need to see it on scale. So I think that these stories are starting to get out there. It gives me some hope. Obviously, I've been very open that 51 housing units is not going to end the homelessness crisis. It's always been the belief that showing it as a proof of concept, that we can see various public institutions try to respond differently to the crisis, can hopefully galvanize the response, ensure that this is really a collective effort. And I will always be open about the fact that every level of government invested in DunHouse. And we really need to see that kind of coordination, that kind of responsibility from every level if we're really serious about moving the needle on the homelessness crisis in a serious way. I mean, just this morning, a report came out from AMO showing that, last year when they issued the report, I think people were in some ways either numb or shocked or surprised that over 80,000 people in Ontario were experiencing homelessness. It's now gone up another 5 to 8%, and over 85,000 people experiencing homelessness. So the curve continues to steepen. And if we don't act, I don't believe homelessness is an intractable problem or that we can't solve it. But the more inaction we have, if we're sitting together in 10 years having a conversation, I fear that it will be far harder to try to reverse course, given where we're headed right now.
And have you calculated, I want to get back to the stories, but I'm sure you have calculated the scale at which the solution is actually needed across Canada. Can you share? Is it
We've looked at some of that.
Yeah. Chronic episodic?
There's been, no, not at all. I apologize. There's been a bit of a lag on my internet end here at the hospital. But, if I understand the question correctly, has there been modeling to look at what kind of investment we need or how many DunHouses we need? I think one thing to be clear is DunHouse is not the only solution and way to try to respond to the homelessness crisis. I think we need a myriad of solutions. Some of it is some of the things we talked about today and actually seen delivered is preventing evictions. We know that CMHC recently had a report showing that about a third of people who are in homelessness or surviving homelessness have been evicted. So there's a real pipeline into homelessness that's getting harder and harder with the prospect of more evictions and the affordability around rent in the private market. We see an 8 to 10 year wait list for social housing. So I think we really need to ensure, and this is where there's, again, lots of encouragement with Build Canada Homes and the initiative from the federal level to see leadership to try to scale social housing and supportive housing across the country. And then really about supportive housing as well. There's a select percentage of clients and people that would benefit from some of the really targeted and intense supports, but that's not everyone. So I think we really need to see a number of these policy levers in play, in action. And some of that modeling has looked different, but I don't think we need to go with a supportive housing for all. It's really about housing for all with some of the various breakdowns across the country.
And so you had started touching on the stories. You highlighted a couple that have been broadcast publicly, and we know success is so much more than the numbers. Can you share with us any stories or moments from DunHouse that stand out to you as especially meaningful, where you saw a real transformation in someone's life? And I did see the article in Toronto Star, which was why I really wanted to get you back on, because those are the stories that mean so much and that create so much impact.
Yeah, and I hope there'll be a chance, not to try to be your producer, but the chance to speak to Jason and obviously others. And I know you've done a terrific job of having people with lived experience on your podcast and wanting to broaden that conversation. And I think, I won't tell Jason's story for him, but I think when you look at the highlights of where he was in his life and what he's now contributing to DunHouse, to the community in Parkdale, being active as a leader and trying to help people with recovery for addictions or mental health challenges, now employed as the advisor to the mayor with lived experience in Toronto.
Wow.
And also finishing his high school diploma. So I'm probably moved and get goosebumps every time I, get to sit down with Jason every few weeks, and the more I hear about all of the incredible things that he's doing to try to reach more people. Again, I can't think of anything more compelling, but there's so many stories we have at DunHouse and obviously across the city for people who've been able to bend the trajectory of health and well-being the direction that they choose. And you'll see it now with some of our older patients who are being able to reconnect with family for the first time in decades. They're coming to visit them after having long periods of not being able to see each other through just acts of survival in the shelter system or living and sleeping rough. So those, every time someone comes up to me in DunHouse and sort of say, hey, this is what I've been able to do, or this has been a real change in my life, being able to reconnect with people I want to, or maybe connect with people now, not have to connect with people they don't want to. I think, that continues to drive some of my hope and will as to why we really need to see these solutions come into real life.
I hope we can get Jason on the show. We'd love to hear about his experience. And you continue to place housing and housing side by side at DunHouse. From what you've seen, how does stable, supported housing change the trajectory of someone's health journey? You have spoken a lot about the direct impacts of stabilization and starting not to rely on emergency services as much. Do we see that there's a restoration of health or longevity or anything like that, or is it too early?
Some of the numbers and the data that I think I've shared is showing that we are seeing a real shift in the acute needs that people are presenting with. So I think that's been really promising. The evidence is very clear. There's been randomized control trials, and for the audience that may not be as familiar, that's sort of the gold standard of medical evaluation or research to identify which interventions are working. And maybe to no surprise, making sure people have access to housing has tremendous benefits for people's mental health trajectories when it comes to substance use disorders, cancer care and recovery, to, again, just being able to access primary care as well. So that's really something that we're starting to see take shape at the very local level at DunHouse, but there is really significant literature and a body of work across the globe showing that this is not a sort of one-hit wonder.
And what drew you personally to lead this work? Was there a moment that fundamentally shifted how you understood your role as a physician beyond the clinic? And what trade-offs also came with choosing this path?
I was really fortunate as a first-year medical student in Ottawa to have the mentorship of Dr. Jeffrey Turnbull almost within the first week, I would say, of medical school. And, that completely changed my thinking and view around the service and the focus that we need in medicine to try to see better outcomes that, can be futile if we don't move upstream from the hospital or the emergency department. You don't need fancy AI algorithms to know who's more likely to come back to the hospital or have a worse health outcome. The person who's getting into a black car and family support in a established address who's being discharged from the hospital versus someone who doesn't have a safe place to go to or has a plastic bag with their belongings. That's probably one of the most powerful predictors to know. And that's not about the quality of care that was provided in the hospital. That's, again, about the social environment and this idea that we keep discharging people the same social conditions and either expect a different outcome or put the onus on bad outcomes on the individual, I think is a real area of failure in medicine. But I think where I'm really encouraged is seeing more and more medical students now, more and more residents, more and more physicians who've dedicated, their lives and their careers to this work, starting to build more of this network and support network for why we need to be doing this, both at the hospital leadership level, but also across primary care and community centers. Wendy Muckle, again, a nurse leader that I got to work with early in my career, again, really shaped my view about, how we need to be thinking, behaving, and acting differently as clinicians. And then when I, go back even before medical school, being born into social housing and knowing that not everyone had the opportunity that my family did, and be able to have that sort of security or an opportunity for my parents as immigrants, again, I think really shaped the trajectory and the opportunities that I had in a really profound way.
Did you just always know that you wanted to be a doctor?
No, I didn't actually. I didn't. So my mother is from Iran and really wanted to pursue a career in law, to be a judge, and my mother, I think, any good that's come from my career or life is, all credit to her. All of my shortcomings are, of course, on me. But she had this real sense of fairness and still does, and I think would have been, an amazing judge or advocate in law, but unfortunately wasn't able to continue with that career in Canada. And made a lot of sacrifices for me and my sister. And so when I was growing up, I had the sense that it was on me actually to vindicate her career as a lawyer, and that I would want to be a human rights lawyer and advocate in the same sort of vein and the same sort of passion that she had around justice and fairness in society at a very broad level. And it wasn't until actually I left school in first year of undergrad. She'd always told me, actually, you're going to end up going into medicine. I thought that made no sense at all, considering I didn't take any high school advanced science credits, no biology, no chemistry.
Wow.
And so when I left and had a chance to reflect about, how and, would want to see a contribution to society and in that in a career to draw real meaning. When I was completing the high school credits, she would never say, I told you so, but she had this vision and idea that started to come to life. So, and she believed in me that I would be able to do it when a lot of friends and folks were saying, this is wild. You're leaving school to go back to high school credits to come back with something you may or may not, know that you'll be able to complete. So it definitely was not in the cards early on in life.
That's incredible. And then the social purpose part, do you feel that was driven also from that human rights and fairness and all of that, or did it evolve based on the mentorship of the doctors you mentioned and all of that, or both maybe?
I mean, I think it's highly relevant today having this conversation. I think, as a son of a refugee and an immigrant from Iran, I think the idea, the push for social justice is in your DNA. And there's probably not any family gatherings early on in life where it wasn't, the major conversation at the barbecue get together wasn't about, unfairness, the ideas of how to try to make things better, to look out for each other. And, really where we needed to see things be done differently. So I credit my parents, but especially the community, and again, really the ongoing, sacrifice from ancestors to try to believe that there needs to be a path to people being able to self-determine their own health and well-being. And there's a lot of sacrifice happening right now in Iran, and there's family there, and so obviously I'm concerned, and again, really wish that we see this self-determination take place across the globe. And I think it's very much impacted me on a personal level since I was born.
And I'll go back to something you said about the system levels, system failure, essentially, and that the health challenges we face is something that's shaped far more by that than by individual choices. If you could think of one system level change you believe would most dramatically improve health outcomes in Canada, what would it be? And, if we had the courage to act on it, what would that one change be?
We need to deliver on housing for all. Yeah, I think this really needs to be the policy focus. Again, it will require coordination across various levels of government. One level cannot do it alone. But, as a clinician, I don't really believe we can talk about universal healthcare without delivering on housing as a human right. And I think much of this is borne out in the data that we talked about people living half as long, about the 7 to 8-fold higher costs in healthcare, the far worse outcomes in mortality and morbidity risks with virtually every health condition that you can imagine. So if we're really serious about human dignity, about health for all, we really need a commitment towards housing for all. And this is not new. I mean, there's been reports on this in the country. There's been tremendous research by colleagues over many, many decades. And, you go back to the Lalonde report in 1974, it's now 52 years ago. There was concern by the Minister of Health and Social Welfare at that time about people's access to housing when there was far more access to social housing, far more investment in social housing. So, I think people would be aghast to be looking at the realities now, but the frameworks and the policies to advance this have been there. The research has been there. I mean, we have enough reports to fill probably both of our offices. And I think what we really need now is the political will across various levels to make this happen for people. And I hope this conversation and the data that we've talked about and the experiences at DunHouse are clear that inaction comes at a very, very high human and economic cost.
Agreed. And sometimes I think we even need to think about the collaboration across departments to if nothing else, make the cost saving, like you said. Like the healthcare system versus housing, like we can really work towards almost like an outcomes purchasing model if we thought about replicating like the work of DunHouse, for example, across Canada.
I think it's a terrific point to be thinking about integration, across ministries, across departments. This has to be an integrated and holistic response. And the challenges in some ways were more fragmented from a policy level now in 2026 than we were in 1974. So it is going to require, exactly as you put, this integration and partnership across sectors, across ministries, if we're really serious about delivering.
Looking ahead, what do you think DunHouse's successes tell us about the future of healthcare? We've talked about scaling similar models. Is there more that you would add about how we can scale these models so more people can benefit from this approach?
I think my hope is that DunHouse offers a playbook or a framework for various local organizations, whether they're in healthcare or outside healthcare or civic institutions, to dedicate public land differently, to dedicate resources differently, to partner with various levels of government to see something concrete happen. But we're going to really need to see that at scale and to move very, very quickly. And there's going to need to be creative solutions depending on where people live. I mean, some of the solutions in rural parts of the country are going to look different, but I think that's actually the exciting feature for me, is that there's going to need to be that ingenuity at various levels in various parts of the country, in various towns and cities. But the hope is that you can show that there's proof in this proof of concept. And it's another proof point to, again, where we've seen a lot of work and literature and evidence pile up. And the hope is we can catalyze this and show that, again, that this isn't just a pipe dream.
So we have a lot to do in this space. Providers, nonprofits, governments, like we have, it's an uphill climb, I think. And like you said, we've kind of fallen back in a number of areas. But if you are to look for a silver lining, is there something right now that brings you hope for our future, despite all the health and social challenges and how entrenched this all feels? What gives you the most hope right now?
I just believe we have to have hope. There's far too many, we talked about some of the really positive stories. I try not to dwell on too much, but there are a lot of tragic stories that play out every day of people who have succumbed to the policy violence of homelessness. And, I think we've touched on some of them. I think there's been some more recognition and advances in new agencies, organizations, commitment of dollars and public dollars to address this. But we're really going to need a collective effort. And I think the hope is to see, the private foundations, private sector, public sector, really rally around this to cut through this really false choice between, this divide that I find has taken shape in a way that I wouldn't have imagined a few years ago. That there's this real disdain towards people who are unhoused. There's this view of, the encampments, that people living there are the failures. Encampments are the policy failure that we're seeing more and more across the country. And they are a symptom of this failure. They are the ugly reality of what people, don't want to see in their parks, don't want to see in various parts of their neighborhood, because we've chronically underdelivered or neglected the kind of action that we need to support people and to invest in people. And so I think my hope is that we cut through this very false divide, that, you're either pro safety or pro encampment. There is a very clear intersection, the idea that, that housing for all can actually address. And I think we just really need to move away and move toward informed solutions that are compassionate, for safety for all, that ensure dignity for all. And from my vantage point as a physician, better health outcomes, which is, my real angle towards this. So that's where I hope we cut through the noise, the divide, and start to see more concrete action in the coming months from various levels of government.
And before you go, I just want to open the floor. We're so lucky to have you as a guest on the show. Is there anything else you'd want to share with the listeners that you haven't already said or that we didn't prompt with questions?
No, again, I really appreciate and following your podcast and the terrific speakers you've had. And I think this has been a wide-ranging conversation. But I think, obviously really centered in the solutions, which I really hope we can really try to focus on as we move forward. But, the only other thing I would add is just the importance of partnership. None of this can be done alone, as a hospital, as a community agency, as one ministry, which we've talked about, sector, and really importance of listening and engaging people with lived experience. I have had some longstanding history and experience in providing care for people who are unhoused and working with people who are unhoused. But, we wouldn't have had as the degree of success with DunHouse if we didn't have a lived experience advisory council at UHN with Michael Armstrong, Opal, and Renee as the OG members, which is now at 9 or 10 people. And one really tangible thing I would say that came out of that just comes to mind is in DunHouse, it was adamant from the council and from colleagues with lived experience that there was going to need to be pet-friendly policies at DunHouse, that people would not go without their family members. And that wasn't the case at all the shelters or all of the housing options or public housing options. And that would go full circle to our conversation about community. How is it not moving to see people who didn't know each other before, now when I'm walking into clinic, all huddled around a puppy named Max, sharing stories, sharing ideas of their old or pets that have passed away and their interest in what, the family member could do for the pet today. And I think these are the ways that I think we need to integrate the data, the lived experience, the storytelling to inform better policies. And so I really appreciate the chance to have that conversation today.
How exceptional. So grateful that you joined us. I hope that we can work with your team to get Jason on the show as well. That would be really exciting. Thank you so much, Dr. Boozary, for joining us and for sharing your work and the successes of DunHouse. I so appreciate your time and the impact you're making. Thank you for joining us on the show today.
Thank you for thinking of me. Hope to talk soon.
Take care. Well, that was our conversation with Dr. Andrew Boozary. What stands out to me is how clearly this work shows that housing is not just a social good, it's foundational to health, dignity, and long-term stability. DunHouse offers a compelling example of what's possible when we design systems and partnerships around people rather than around silos, and when we have the courage to measure success not just by numbers, but by lives changed. If this episode resonated with you, please share it, subscribe, and join us again next time as we continue exploring what it truly means to be on the way home.
You're listening to On the Way Home with your host, Emmy Kelly.